There is a moment in a doctor's office that happens more often than most people realize. It is quiet, unassuming, and it rarely makes it into the dramatic medical scenes we see on television. But it is one of the most important moments in a person's health journey, especially after the age of 60. You walk into the exam room. The air is cool. There is that familiar smell of antiseptic and paper covers on the examination table. You have been thinking about this appointment for weeks, maybe months. You have been living with the discomfort, the pain, the limitation that has slowly been reshaping your days. And finally, you are sitting across from a surgeon, someone with years of training, steady hands, and a confident demeanor. They show you the images. They point to the spot on the scan. And they say the words that feel like both a diagnosis and a solution. We can fix this. And in that moment, something happens inside you, a wave of relief. Because finally, someone has a plan. Finally, there is an answer that does not involve just managing symptoms or waiting to see what happens. There is a procedure. There is a date on the calendar. There is a path forward. You are told the risks, of course. Every surgeon goes through the list: infection, bleeding, reactions to anesthesia. But the way it is presented, it sounds like the fine print on a car rental agreement. Yes, these things exist in theory, but they probably will not happen to you. And the alternative, doing nothing, sounds so much worse. So you nod, you sign the form, and you walk out with a sense of relief, feeling that you have taken control of your health. But here is what I have learned over years of practicing medicine, of sitting in those same consultations and watching what happens in the weeks and months that follow. That moment of relief, that feeling that you have made the right decision, can sometimes be the most deceptive moment in all of medicine. Because there is a question that often goes unasked in that room. A question that changes everything about how we should think about surgery after a certain age. And it is not, can we do this surgery? We are remarkable at performing surgeries. The technical skill of modern medicine is extraordinary. A surgeon can replace a joint, repair a valve, remove a troublesome organ with precision that would have seemed like magic just a few decades ago. The question that matters, the question that can mean the difference between regaining your life and losing something far more precious, is not about whether the surgery is technically possible. The question is this: is your body ready to survive the surgery? Now, I know what you might be thinking. Of course my body is ready. I am getting the surgery because something is wrong. That is the whole point. But what I am talking about here is something deeper than the condition that brought you to the surgeon's office. I am talking about something that most people have never even heard of, something that surgeons themselves do not always fully account for when they are focused on the technical success of the procedure they are about to perform. I am talking about physiological reserve. It is a concept that sounds academic, but it is actually one of the most practical and powerful ideas in all of medicine, especially for anyone over 60. Physiological reserve is the cushion your body has to handle stress. It is the extra capacity your heart has to pump when it is pushed. It is the strength your immune system has to fight off an infection that it did not see coming. It is the cognitive clarity your brain can maintain even when it is flooded with anesthetic drugs and inflammatory signals. When you are 30 years old, your physiological reserve is like a savings account with a very large balance. Your body can handle a major stressor, a surgery, an illness, an injury, and still have plenty left over to recover. Your heart can manage the fluid shifts. Your lungs can handle the sedation. Your brain can clear the fog. Your muscles can bounce back from days of bed rest. But as we age, that reserve naturally diminishes. It happens slowly, quietly, in ways that are not always visible on the outside. You might feel fine. You might walk every day, eat well, take care of yourself. But the cushion is smaller than it used to be. And here is the crucial insight that changes everything. A surgery that is perfectly safe for someone with a large physiological reserve can become a completely different proposition for someone whose reserve has worn thin. And yet, that is rarely part of the conversation in the surgeon's office. Instead, the conversation is about the problem: the arthritic hip, the blocked artery, the herniated disc. The surgeon is an expert in that problem. They know exactly how to fix it, and they will tell you, truthfully, that the surgery itself has a high success rate. The hip replacement is successful. The bypass graft is patent. The disc is decompressed. But success in the operating room and success in your life over the next 12 months are not always the same thing. I have sat with patients 6 months after a surgery that went perfectly from a technical standpoint, watching them struggle to understand what happened. They expected to feel better. They expected to be back to their lives. Instead, they are exhausted. They are weaker than before. They are dealing with new problems they never anticipated, and they are left wondering if they made a terrible mistake. The truth is, they did not make a mistake. They made a decision based on the information they were given, and the information they were missing, the piece that could have changed everything, was a deeper understanding of how their body, at this stage of life, would respond to the immense stress of major surgery. So today, I want to walk you through something that most doctors do not have time to explain in a 15-minute consultation. I want to show you the 5 categories of surgery that carry risks for older adults that are often underestimated, not because the surgeons are careless, but because the risks are hidden in a different part of the equation. And more importantly, I want to give you something even more valuable than a list of procedures to avoid. I want to give you the framework, the questions to ask, the understanding that allows you to walk into that consultation not as a passive recipient of medical advice, but as an informed partner in your own health decisions. Because here is what I have come to believe after years of practicing medicine and watching the patterns play out. The goal is not to never have surgery. The goal is to have the right surgery at the right time for the right reasons, when your body is truly ready for what is about to happen. And sometimes, the most powerful decision you can make is not to say yes to the first solution that is offered, but to pause, to ask deeper questions, and to make sure that the path you are choosing leads to the life you actually want to live. Let us begin. To understand why so many people walk into surgery with expectations that reality does not quite meet, we have to first understand a fundamental misunderstanding that runs through modern medicine. It is not a misunderstanding that belongs to patients alone. It is woven into the way we measure success, the way we talk about outcomes, and the way we make decisions in those brief moments before a procedure. We tend to think of surgery as an event. You go in, they fix the problem, you wake up, and then, over time, you heal. The event is the surgery itself. And if the surgery goes well, if there are no complications on the table, if the surgeon achieves what they set out to achieve, then we call it a success. But here's what that framing misses. Surgery is not an event. Surgery is a trauma. It is a carefully controlled, intentional trauma, but it is trauma nonetheless. And when you subject the human body to trauma, what follows is not simply a period of healing. What follows is a cascade, a chain reaction that touches every system in the body, often in ways that have nothing to do with the specific area that was operated on. Think about what actually happens during a major surgery. The body is opened. Tissues are cut, retracted, manipulated. Anesthesia is administered. And it does not just put you to sleep. It temporarily shuts down normal regulatory functions. Your breathing is taken over by a machine. Your blood pressure is managed by medications that override your body's natural controls. Your heart rate, your fluid balance, your temperature regulation, all of these are handed over to the medical team and the drugs they are administering. And then there is the inflammatory response. This is one of the most overlooked aspects of surgical recovery, and it is absolutely central to understanding why older bodies respond differently. When the body experiences trauma, it releases a flood of inflammatory signals. These signals are designed to protect, to begin the process of repair, but they are also powerful. They affect the brain, causing something we call post-operative delirium, a state of confusion that can last for days, weeks, or sometimes never fully resolves. They affect the muscles, accelerating the breakdown of tissue in ways that lead to profound weakness. They affect the heart, the kidneys, the immune system. In a young, healthy body with abundant physiological reserve, this inflammatory cascade is managed. The body absorbs the shock, mounts its response, and then gradually returns to equilibrium. The inflammation subsides, the confusion clears, the strength returns. But in an aging body, especially one with underlying vulnerabilities that may not have been obvious before surgery, that same cascade can become overwhelming. The body's ability to regulate inflammation diminishes with age. The systems that normally put a brake on the inflammatory response become less efficient. So instead of a controlled fire that burns out on its own, the inflammation can persist. It can spread. It can create new problems that were not there before the surgery ever happened. This is why you sometimes hear stories of older adults who went into surgery for something relatively straightforward, a hip fracture, a hernia, a gallbladder, and came out a different person. Not just physically weaker, but cognitively changed, not quite themselves, struggling with confusion, with fatigue, with a fragility that was not there before. The surgery itself was technically successful. The surgeon did everything right. But the body's response to the trauma of surgery was more than the person's physiological reserve could handle. And here is where the common misunderstanding becomes truly consequential. Most people believe that if a surgery is offered, it must be safe. We assume that doctors would not recommend something unless the benefits clearly outweigh the risks. And for many surgeries, that is absolutely true. But what we do not always appreciate is that the risk calculation changes depending on who is receiving the surgery. A procedure that carries a 2% risk of serious complications in a 50-year-old might carry a 15% risk in an 80-year-old. But if the consent form lists the same risks and the surgeon uses the same language, it is very easy to miss that the probabilities have shifted. The words are the same. The underlying reality is not. There is another layer to this misunderstanding, and it has to do with how we think about aging itself. We are taught to believe that aging is a process of gradual decline, something we can see and feel. But the truth is, much of the decline that matters for surgical outcomes is invisible. It lives in the cellular level, in the mitochondria that power our cells, becoming less efficient, in the immune cells that become less responsive to new threats, in the neural connections that take longer to reform after disruption. You cannot see these things on an MRI. You cannot feel them on a morning walk, but they are there, quietly reshaping the landscape of your body's resilience. And when surgery comes along, it tests that resilience in ways that everyday life never does. This is why the question is not simply, do I need this surgery? That is the question we are trained to ask. But it is not the only question, and for people over 60, it may not even be the most important question. The more important question is, what is the true cost of this surgery to my body, given who I am right now? And that question requires a different kind of answer. It requires looking not just at the condition that brought you to the surgeon, but at the whole picture of who you are. Your baseline strength, your cognitive sharpness, your nutritional status, your social support, the medications you take, the hidden vulnerabilities that may not be causing symptoms today, but could become critical when your body is under the immense stress of surgery. This is where the gap often lies. The surgeon is focused on the specific problem they are trained to fix. And they should be. That is their expertise. But no one is looking at the whole picture. No one is asking the question about your physiological reserve and whether it is sufficient to carry you through not just the surgery itself, but the recovery that follows. And that is why, in the next part of this conversation, I want to show you what this looks like in real life. Not through statistics or studies, but through the stories of two people who walked into the same hospital with the same condition, who received the same surgery from the same skilled hands, and who emerged into completely different realities. Because understanding why their paths diverged is the key to understanding how you can make a more informed decision about your own health. Let me tell you about two people. I will call them Margaret and Eleanor. They were both 72 years old. They both lived in the same community, not far from the same hospital. And within a span of 6 months, they both found themselves sitting in the office of the same orthopedic surgeon, looking at the same black and white images of their spines, hearing the same recommendation. A spinal fusion. 2 levels. The kind of surgery that is performed thousands of times a year across the country, considered routine by the standards of modern spine surgery. Margaret had been dealing with back pain for years. It started as a dull ache after long days in the garden, then progressed to a sharp, shooting sensation that traveled down her leg. She had tried physical therapy. She had tried injections. She had modified the way she moved, the way she exercised, the way she lived. But the pain kept creeping further into her life. She was losing sleep. She was losing the ability to walk her dog in the mornings. She was beginning to feel like her world was shrinking. When the surgeon told her that surgery could address the nerve compression and give her back her mobility, she felt a surge of hope. This was the solution she had been waiting for. She trusted the surgeon. She trusted the process. And she said yes. Eleanor had a different story. Her back pain was more recent, but it was severe. She had been helping her grandson move into a new apartment when she felt something give. The pain that followed was unlike anything she had experienced, a searing, relentless sensation that made it difficult to stand, to sit, to find any position of comfort. She was not someone who liked to make a fuss, but this time she knew she needed help. The same surgeon, the same diagnosis, the same recommendation. Eleanor said yes as well. Both women went into the operating room on different days, both with the expectation that they would emerge on the other side of this experience with less pain and more function. Both had surgeons who were technically excellent, who performed the procedures without complication, who achieved exactly what they set out to achieve. And then the paths diverged. Margaret's recovery was slow. The first few days in the hospital were what she expected: discomfort, fog from the anesthesia, the slow process of getting out of bed with the help of a physical therapist. But as the weeks passed, something unexpected happened. Instead of gaining strength, she seemed to be losing it. The fatigue that settled into her bones did not lift. She would wake up after 10 hours of sleep feeling as though she had not slept at all. Her appetite disappeared. The physical therapist told her she needed to walk more, but every time she tried, her legs felt like they were weighted down with sandbags. And then there was her mind. She would lose her train of thought in the middle of a sentence. She would walk into the kitchen and forget why she was there. Her daughter would call, and she would struggle to find the words she was looking for. At first, she told herself it was just the stress of recovery. But as the months went on, she began to wonder if something was seriously wrong. 8 months after her surgery, Margaret was still not back to her baseline. She was using a walker when she had not needed one before. She had lost 15 pounds she could not afford to lose. Her mind felt like it was moving through mud. And the back pain? It was different, certainly. The sharp, shooting sensation was gone. But there was a deep, aching discomfort that had taken its place, along with a stiffness that made it hard to bend, to twist, to do the things she had once loved. Eleanor's experience was almost unrecognizable in comparison. She was walking within 2 days. She went home on the 4th day. Within 2 weeks, she was preparing her own meals. Within 6 weeks, she was back to her morning walks, slower than before, but steady. The pain that had sent her to the surgeon was gone. She had some stiffness, some lingering soreness, but she described her recovery as easier than she had expected. She felt like herself. 2 women, same age, same surgery, same surgeon. Completely different outcomes. What happened? If you look at the medical records, both surgeries were documented as successful. Both patients were discharged in stable condition. By every standard measure of surgical quality, there was no meaningful difference between them. But Margaret and Eleanor were not the same person when they walked into that operating room. And that is the piece that the surgical notes do not capture. Margaret had been living with chronic pain for years before her surgery. And chronic pain does something to the body that goes far beyond discomfort. It changes the way the nervous system functions. It disrupts sleep patterns, often for years, creating a cumulative sleep debt that affects immune function, cognitive clarity, and metabolic health. It leads to a sedentary lifestyle, which over time erodes muscle mass and cardiovascular fitness. Margaret had lost more than she realized. She had lost her physiological reserve, slowly, quietly, over the years that the pain was stealing her mobility and her rest. Eleanor, by contrast, had been active and healthy right up until her injury. Her pain was acute, not chronic. She had not spent years losing muscle mass or accumulating sleep debt. When she went into surgery, her body had the reserves it needed to mount a controlled inflammatory response, to rebuild tissue, to clear the anesthetic drugs, to restore normal function. The surgery itself was the same, but the bodies that received that surgery were not the same, and the outcomes reflected that difference in ways that no preoperative checklist had captured. This is the hidden reality of surgery after 60. It is not that the procedures themselves become dangerous. It is that the margin for error narrows. The cushion of physiological reserve that protects younger bodies from the cascade of stress, inflammation, and deconditioning is thinner in older bodies. And when that cushion is already depleted by chronic illness, chronic pain, frailty, or the simple accumulated wear of years, even a technically perfect surgery can tip the balance into a recovery that never fully returns to baseline. Margaret's story is not rare. I have seen versions of it play out countless times. A person who is managing, who is getting by, goes into surgery expecting to come out better, and instead comes out diminished in ways that no one prepared them for. Not because the surgery was unnecessary, often it was necessary, but because the timing, the preparation, and the understanding of their individual resilience were not fully considered. And that is why, when we talk about the 5 high-risk surgeries that doctors urge you to reconsider after 60, we are not talking about procedures that are inherently bad. We are talking about procedures that, for certain people, under certain conditions, carry risks that are not always visible in the moment of decision. Understanding those risks means understanding not just the surgery itself, but the hidden terrain of your own body. And that is what we will turn to next. To understand why certain surgeries carry a different weight after 60, we have to go beneath the surface. We have to look not at the scalpel or the implant or the technique, but at the conversation that happens inside the body when it is subjected to the profound stress of a major procedure. Because the truth is, the risks that matter most are rarely the ones listed on the consent form. They are not the immediate risks of bleeding or infection, though those are real. They are the deeper, slower, more insidious risks that unfold over weeks and months. And they are rooted in a mechanism that most people have never been taught to think about. Let me walk you through what actually happens when an aging body undergoes major surgery. It begins with anesthesia, and here we need to understand something that is not widely appreciated. Anesthesia is not simply sleep. Sleep is a natural, restorative state that the brain enters and exits on its own terms. Anesthesia is a pharmacologically induced coma. It is a controlled shutdown of the brain's normal functions, achieved through drugs that suppress neural activity in ways that are powerful and, in older brains, potentially prolonged. The reason this matters is that the aging brain is more vulnerable to the effects of these drugs. The blood-brain barrier, which protects the brain from circulating substances, becomes more permeable with age. The liver and kidneys, which clear anesthetic drugs from the system, work more slowly. And the neural networks themselves, which have spent a lifetime refining their connections, are less resilient when they are disrupted. This is why postoperative delirium is so common in older adults. It is not simply confusion. It is a neurocognitive event, a temporary but sometimes lasting disruption of the brain's ability to organize itself. For some, it passes in a day or two. For others, it lingers, evolving into a longer-term cognitive decline that can look like the rapid onset of dementia. The surgery was on the spine, or the hip, or the heart, but the brain bears a cost that was never part of the conversation. Then there is the cardiovascular system. During major surgery, the body undergoes significant fluid shifts. Blood is lost, fluids are infused. The heart is asked to manage a constantly changing load while under the influence of medications that alter its natural rhythm and contractility. For a younger heart, this is manageable. For an aging heart, especially one with undiagnosed stiffness or subtle valvular changes, the stress can be enough to tip it into failure. Not the dramatic, sudden failure that we picture, but a quieter, more persistent decline in function that shows up weeks later as shortness of breath, swelling in the legs, and inability to do what was once easy. The kidneys are another hidden casualty. They are exquisitely sensitive to changes in blood pressure and flow. During surgery, blood pressure is deliberately manipulated. It is lowered to reduce bleeding, raised to maintain perfusion, managed moment by moment by the anesthesia team. For kidneys that have lost some of their reserve, and most kidneys do with age, this seesaw of pressure can cause damage that does not show up immediately. It shows up months or years later as a slow, irreversible decline in function that was not there before the surgery. But the mechanism that perhaps matters most and is least understood is what happens to muscle. When the body is subjected to the trauma of surgery, it enters a state of profound catabolism. That is a scientific term for breakdown. The body begins breaking down its own tissues to fuel the healing response. And the tissue it breaks down most readily is muscle. For a young person, this is not a crisis. Muscle mass is abundant. It is rebuilt quickly once recovery begins. But for an older adult, muscle is precious. It is the currency of independence. It is what allows you to get out of a chair, to climb stairs, to carry groceries, to catch yourself when you stumble. And older adults are already losing muscle at a rate of 1 to 2% per year after the age of 50. Surgery accelerates that loss dramatically. A single major surgery can erase years of preserved muscle mass in a matter of weeks. What makes this even more consequential is that the loss is not just about strength. Muscle is an endocrine organ. It communicates with the rest of the body, releasing signaling molecules that influence immune function, metabolic health, and inflammation. When muscle is lost, that communication network is disrupted. The body becomes more inflammatory, more insulin resistant, more vulnerable to the very cascades that surgery triggers. This is the hidden mechanism that explains why two people with the same surgery can have such different outcomes. It is not about the skill of the surgeon, though that matters. It is about what the body brings to the operating table. The person who enters surgery with abundant physiological reserve, with strong muscles, clear cognition, well-functioning kidneys, a resilient heart, has the resources to absorb the trauma, ride out the inflammatory wave, and rebuild. The person who enters with depleted reserves has no cushion. The trauma overwhelms the system, and the recovery becomes not a return to baseline, but a settling into a new, lower baseline. There is one more layer to this mechanism that deserves attention. It is called the stress response. Surgery activates the hypothalamic pituitary adrenal axis, the body's central stress response system. Cortisol surges, and cortisol, while essential for healing in the right amounts, becomes destructive when it remains elevated. It breaks down tissue. It suppresses immune function. It impairs sleep. It clouds cognition. In a young body, the stress response is self-limiting. It rises to meet the challenge and then subsides. In an aging body, the feedback loops that normally shut down the stress response become sluggish. Cortisol remains elevated longer. The stress state persists, and the body continues to break itself down even after the healing should have begun. This is why some older adults describe feeling like they never fully recovered from their surgery. They are not imagining it. Their bodies are stuck in a stress state, their reserves depleted, their systems struggling to find equilibrium. The surgery is over, the incision is healed, but the internal landscape has been permanently altered. Understanding this mechanism changes the way we think about surgical decisions. It moves the conversation away from the simple binary of whether a surgery is indicated or not, and toward a more nuanced assessment of readiness. Is this body, with its particular constellation of strengths and vulnerabilities, prepared to handle the trauma that is about to be inflicted? And if not, what can be done to build that readiness before the operating room? These are the questions that rarely get asked in the 15-minute consultation, but they are the questions that determine whether surgery becomes a path to restoration or a path to decline. And in the next part of this conversation, we will take these mechanisms and apply them to the 5 categories of surgery where the risks are most often underestimated, giving you the framework you need to have a different kind of conversation with your own doctors. Now we arrive at the heart of the matter. 5 categories of surgery that, for people over 60, carry risks that are often underestimated. But I want to be very clear about what we are doing here. This is not a list of procedures to fear. It is not a warning to avoid surgery at all costs. That would be irresponsible and, frankly, untrue. There are times when surgery is not just beneficial, but essential. A fractured hip, a rapidly progressing infection, a heart valve that is failing and cannot wait. These are situations where the risk of doing nothing far exceeds the risk of intervention. What we are doing instead is something more subtle and, I believe, more useful. We are identifying the surgeries where the calculus is most delicate, where the benefits and risks are closely balanced, where the decision requires a deeper understanding of your own body's resilience, and where, too often, the conversation in the surgeon's office focuses exclusively on the problem being fixed, and not enough on the person who is carrying that problem into the operating room. Let us begin with the first category, spinal fusion. This is one of the most common major surgeries performed on older adults, and it is also one where the gap between technical success and personal success can be widest. Spinal fusion involves fusing 2 or more vertebrae together to stabilize the spine, typically in response to degenerative disc disease, spinal stenosis, or spondylolisthesis. The surgery itself is technically demanding. It is long. It involves significant tissue disruption, and it places the patient on a recovery trajectory that can last 6 months to a year. The hidden risk here is not the surgery itself, it is the recovery. Spinal fusion demands prolonged immobility. Patients are often restricted from bending, lifting, twisting for months. And immobility, as we have discussed, is the enemy of physiological reserve. Muscle mass evaporates. Cardiovascular fitness declines. The body's metabolic processes slow. And for someone who entered surgery with already diminished reserves, this period of enforced inactivity can trigger a cascade of decline from which it is very difficult to recover. There is also the question of whether the surgery achieves what it promises. Studies on spinal fusion in older adults show that while many patients experience relief from the specific nerve pain that prompted the surgery, a significant number do not return to their previous level of function. They trade one kind of pain for another, nerve pain replaced by stiffness, discomfort, and the lingering effects of a major recovery that their bodies struggled to complete. This is not to say spinal fusion is never the right choice. For some, it is transformative, but it is a surgery that demands careful consideration of your baseline function. If you are already frail, already struggling with mobility, already carrying the weight of chronic pain that has eroded your reserves, the risks may outweigh the benefits in ways that are not always visible in the moment of decision. The second category is major cardiac surgery, coronary artery bypass grafting. Valve replacement. These are life-saving procedures, and there is no question that for certain conditions, they are essential. But they are also among the most physically demanding surgeries the body can undergo. What many people do not appreciate is that cardiac surgery is not just about the heart. It involves placing the patient on cardiopulmonary bypass, a machine that takes over the work of the heart and lungs. And that machine, while extraordinary, subjects the body to a level of physiological stress that is unlike almost any other medical intervention. Blood is circulated outside the body. Inflammatory mediators are activated on a massive scale. The brain is exposed to microemboli, tiny particles that can affect cognitive function. The term pumphead used to be a casual way of describing the cognitive decline that's sometimes followed bypass surgery. It was dismissed as an inevitable side effect. But what we have learned since is that this cognitive impact is real and can be lasting, particularly in older adults whose brains have less reserve to compensate. There are also the physical demands of recovery. Cardiac surgery requires opening the chest, which means weeks of limited mobility while the sternum heals. Physical therapy is essential, but also exhausting. And for someone whose heart was already compromised going into surgery, the recovery can be a precarious balancing act. Again, the question is not whether these surgeries have value. They save lives. But the decision to proceed with major cardiac surgery after 60 requires a clear-eyed assessment of your overall resilience. If the surgery is being recommended for symptoms that are manageable, if there is time to optimize your conditioning, your nutrition, your overall health before going in, those are conversations worth having. The third category is complex abdominal surgery, Whipple procedures for pancreatic conditions, complex liver resections, extensive bowel surgeries. These procedures involve long operating times, significant blood loss, and prolonged recovery periods, and they carry a risk that is particularly relevant to older adults: post-operative ileus, or the prolonged shutdown of the digestive system. When the intestines are manipulated during surgery, they can essentially stop working. For a younger patient, this is a temporary inconvenience, managed with IV fluids and patience. For an older patient, especially one who is already vulnerable, prolonged ileus can mean extended hospital stays, nutritional deficits, and the kind of immobility that accelerates muscle loss. There is also the metabolic demand. Major abdominal surgery triggers an enormous inflammatory response, one that requires significant physiological reserve to navigate. The body is asked to heal a large wound while simultaneously managing the stress of anesthesia, fluid shifts, and the disruption of normal digestive function. For someone with limited reserves, this can be overwhelming. The fourth category is elective joint replacement, hip replacement, knee replacement. These are among the most successful surgeries in all of medicine when performed on the right patient. They restore mobility, reduce pain, and dramatically improve quality of life. But the phrase, "when performed on the right patient," is doing important work here. Joint replacement is elective. That means there is time to optimize your condition before surgery, time to ask whether your pain is truly refractory to non-surgical approaches, time to consider whether your overall health is stable enough to support a major recovery. The hidden risk in joint replacement is not the surgery itself, but what it demands afterward. Physical therapy begins within hours of surgery. It is rigorous. It requires strength, motivation, and cognitive clarity to follow instructions and avoid complications. For a patient who enters surgery already deconditioned, already struggling with cognitive issues, already carrying multiple chronic illnesses, the recovery can become a struggle rather than a restoration. And there is the question of longevity. Joint replacements have a lifespan. For a 60-year-old, a new hip may need to be revised in 15 to 20 years. That second surgery carries higher risks than the first. The decision to replace a joint is a decision to commit to a surgical trajectory that may not end with one procedure. The fifth and final category is elective hernia repair. This one surprises people. Hernia repair is often presented as minor surgery, and in a young, healthy person it is. But in an older adult, especially one with underlying pulmonary or cardiac issues, the story changes. Hernia repair, even when done laparoscopically, requires anesthesia. It requires abdominal wall manipulation, and it often involves a period of restricted activity while the repair heals. For someone whose physiological reserve is already thin, these seemingly minor stresses can accumulate in ways that are not anticipated. There is also the question of urgency. Many hernias in older adults are asymptomatic or minimally symptomatic. They have been present for years. The risk of strangulation, the feared complication where a loop of intestine becomes trapped and loses blood flow, is real, but low. And that creates a space for a different kind of decision. One where watchful waiting, with careful monitoring, may be a reasonable alternative to proceeding directly to surgery. Now I want to pause here and address something important. As I walk through these categories, I can imagine some of you feeling a sense of unease. Perhaps you have had one of these surgeries yourself. Perhaps a loved one is scheduled for one soon. And you may be wondering if I am suggesting that these surgeries should never happen. I am not suggesting that. What I am suggesting is that the decision to proceed with any of these surgeries after 60 requires a level of scrutiny, a depth of conversation, a consideration of the whole person that is often missing from the standard surgical consultation. And that brings us to the insights that most people miss. The 3 key understandings that can transform how you approach these decisions and ensure that if you do choose surgery, you do so with your eyes fully open and your body as prepared as it can possibly be. We have walked a long path together in this conversation. We have looked at the hidden mechanism of physiological reserve. We have seen how the same surgery can produce radically different outcomes depending on what the body brings to the operating table. We have examined the 5 categories where the risks are most often underestimated. And now, we arrive at the final piece of this puzzle. The 3 insights that most people miss. The understandings that can transform a moment of vulnerability into a moment of informed, confident decision-making. The first insight is this: surgery is not a single event. It is a process that begins long before you enter the operating room and extends far beyond it. And the most powerful thing you can do is to shift your focus from the day of the surgery to the weeks and months that precede it. What does this look like in practice? It means that if a surgeon recommends a major elective surgery, you do not have to say yes immediately. You can ask, what can we do to prepare my body for this? How can we build my physiological reserve before we subject it to the stress of the procedure? There is a field of medicine called prehabilitation. It is the practice of preparing the body for surgery through exercise, nutrition, and targeted interventions before the procedure ever happens. And the evidence for its effectiveness is compelling. Patients who participate in prehabilitation programs enter surgery with greater strength, better nutritional status, and higher cardiovascular fitness. They have shorter hospital stays. They have fewer complications. They recover faster and more completely. But prehabilitation requires time. It requires a recognition that the weeks before surgery are not simply a waiting period, but an opportunity to invest in your body's resilience. And it requires a surgeon who is willing to partner with you in that preparation, rather than rushing to schedule the procedure. If your surgeon says, "We need to do this next week," that is a reason to pause and ask why. Is there a true urgency? Or is this simply the rhythm of the surgical schedule? Because for most elective procedures, taking 4 to 6 weeks to optimize your condition is not a delay. It is an investment in success. The second insight is about the question you must ask before any surgery. Not, what are the risks, though you should ask that, but something deeper. Something that gets to the heart of what you are trying to achieve. Ask your surgeon, what does success look like 6 months from now? And then listen carefully to the answer. If the answer is focused entirely on the technical outcome, the joint is stable, the graft is patent, the hernia is repaired, that tells you something important. It tells you that the surgeon is thinking about the procedure, not about your life. A surgeon who understands the full picture will talk about function, about returning to the activities that matter to you, about what your days will look like when the recovery is complete. And if the answer is vague or uncertain, that is information too. It may mean that the outcomes for someone in your specific situation are not as predictable as you would hope. It may mean that the surgery is being recommended because it can be done, not because it is the right path for you. This question also opens the door to a deeper conversation about alternatives, because sometimes the best surgical outcome is not the one that comes from surgery. Sometimes the best outcome comes from a different approach altogether: physical therapy, pain management, lifestyle modification. And sometimes it comes from accepting that a condition is manageable without intervention, and that the risks of surgery outweigh the benefits for someone in your particular situation. The third insight is perhaps the most important of all. It is about understanding that your body after 60 is not your body at 40. And that is not a limitation to be mourned. It is a reality to be honored. When we are younger, we are taught that the body is resilient, that it will bounce back from almost anything. And for the most part, that is true. But after 60, the rules change. The body's ability to absorb stress and recover fully is not what it once was. And that means the decisions we make about our health need to reflect a different set of priorities. The priority is not simply to fix every problem that arises. The priority is to preserve function, to maintain the ability to do the things that make life meaningful, to protect the reserves you have because they are more precious now than they have ever been. This is a shift in mindset that can be difficult to embrace. We are conditioned to believe that more intervention is better, that if something is wrong, we should fix it. But in the context of an aging body, sometimes the wisest decision is the one that does the least harm, the one that allows you to keep what you have rather than risk losing it in pursuit of something you may not gain. I am not suggesting that you should never have surgery. That would be as misguided as suggesting that surgery is always the answer. What I am suggesting is that the decision requires a level of thoughtfulness, a depth of consideration that is often missing from the standard medical conversation. And this is where you have power. You have the power to slow things down, to ask the questions that matter, to insist on a conversation that looks at the whole picture, not just the images on the screen. To seek a second opinion, not because you distrust your surgeon, but because you understand that important decisions deserve multiple perspectives. You have the power to build your reserve before you spend it, to invest in your strength, your nutrition, your mobility, knowing that these are the currencies that will matter most if you ever do need to undergo a major procedure. And you have the power to say no, to recognize that sometimes the best decision is the one that preserves your current function, rather than risking it for an uncertain gain. I have sat with too many patients who wish they had asked different questions before their surgery, who wish they had taken more time, who wish someone had explained to them that the technical success of a procedure and the success of their life after it are not always the same thing. And I have sat with patients who made the decision to wait, to prepare, to explore alternatives, and who emerged on the other side with gratitude for the choice they made. This is what I want you to take away from this conversation. Not a list of surgeries to avoid, not a source of fear or anxiety, but a framework, a way of thinking about your health that honors the reality of your body at this stage of life. A set of questions that you can carry into any consultation, and a quiet confidence that you have the right to be thoughtful, to take your time, and to make decisions that align not just with what is medically possible, but with what is truly best for the life you want to live. The goal is not to never need surgery. The The goal is to have the right surgery at the right time for the right reasons, with a body that is as ready as it can possibly be. And that goal is within reach. It requires awareness. It requires conversation. It requires a partnership with your doctors that goes beyond the standard script. But it is possible. So the next time you find yourself in that exam room, looking at the images, hearing the recommendation, I hope you will remember this conversation. I hope you will pause. I hope you will ask the questions that matter. And I hope you will make a decision that honors not just the problem that needs fixing, but the person you are, the life you live, and the future you are still building. Thank you for spending this time with me. Take care of yourself. And as always, stay curious about your health.